It's all clear, right? Shanuf.
Yes, sir. Yes, sir. The voice is perfect, sir.
Yep. Yep. So it's like we'll start by 8:30, sharp 8:30, right? So I'll be here. ഞാൻ ഉണ്ടാവും.
Okay, sir. Sure, sure.
Okay, sure.
ഇത് വാട്സപ്പ് ഇത് യൂട്യൂബ് ലൈവ് ലിങ്ക് ആണ് കേട്ടോ. യൂട്യൂബ് ലൈവ് ലിങ്ക്.
All good, അല്ലേ?
Sir, ഒന്ന് full screen ആക്കാൻ പറ്റുമോ sir?
Yeah, yeah.
Yes, sir. Everything is perfect, sir. So I guess we will start. Good evening, everyone. Respected Dr. SHIBU sir, members of the IADPE, and dear doctors. So we welcome you back for another episode of Learn from Our Master Series organized by IADPE, and it's always a pleasure to come back to this podcast. So for those who are attending our webinars for the first time today, we'll just give a brief introduction of ourselves. We are the International Association for Dental Practice Excellence, a dental platform in which we believe quality education always ensure predictable outcomes of dentists of all disciplines and abilities. Our organization is established based on the fact that the dentistry is complex and requires ongoing learning experience. So we conduct various webinars and workshops to enhance the skills of dental professional and guide their dental journey. So without further ado, let us start our series of episode in which our topic of discussion is Restore, Recreating the Natural Teeth, and Biomimetic Restorative Journey, given by Dr. SHIBU sir. To speak a few words about sir, Dr. SHIBU Sridhar completed his BDS from A.B. Shetty Memorial Institute of Dental Science and completed his Masters in Conservative Dentistry and Endodontics from D.Y. Patil Dental College. He is completely into private practice in the Outlook Center for Advanced Dentistry in Ernakulam, Kerala. He's a member and a green badge holder in RIPE Global Organization and recently completed his mastership in biomimetic dentistry by the great Dr. David Alimenso. He has done various publications in the field of endodontics and adhesive dentistry and done multiple lectures and workshops across India. So without wasting more time, I would like to invite Dr. Shibu sir for today's discussion. Sir, please.
Thank you, Shanu, for the introduction. And let me welcome you all to Biomimetic Dentistry. See, something which we have to understand, a sad fact is that though it is like human race is developed, we left our restorative dentistry in Stone Age. We would have learned in schools, we would have seen movies of how man evolved from the Stone Age to the modern era.
Change.
But
Predators,
the biggest
weather,
issue
and
was
diseases.
we left our restorative dentistry there in the Stone Age.
Change. Predators, weather.
So let me start the session by sharing a case. So you can see on the screen a badly mutilated maxillary second. So whenever we see such a case, we would do a root canal treatment. Sometimes seeing the furcation being involved, we may think of extracting the teeth and replacing with an implant also, but we always focus on saving the natural teeth. So here it's a rather, I would say, a common phenomenon that we would go ahead with a root canal treatment, then we would go ahead with a post and core, and then a crown. So let's see biomimetically how to restore such a badly mutilated teeth. So here I would require a bit of gingivectomy to acquire the deep margin. And after the gingivectomy, we have to control the bleeding. So I have placed over here a bit of Triumph's astringent retraction paste. Once the bleeding has stopped, we would go again with rubber dam isolation. So this is something which is very important to us in modern dentistry. That is, for any sort of adhesive dentistry, it's imperative that fabulous isolation is with rubber dam is mandatory. So you can see here the tooth is very well isolated. Of course, some tricky areas are here, like the distoproximal fluting. And you can see a bit of Teflon is being packed into that fluting, and we have attained good isolation. Also, on top of Teflon, you can also see a floss tie over there. If you look at the screen, you can see. You can see a floss tie which is securing everything nicely. Now, again, there are certain areas which in conventional dentistry, we never cater to. Like you can see multiple cracks into the dentin. These are the early cracks which would propagate further and finally would become a fracture, and you would see that the tooth breaks. So the cracks are dissected off, and you can see the magnified image of crack dissection. And then we would go ahead building the proximal areas. Mesially, I have built up the mesioproximal side with a sectional matrix band And distally, since the third molar is not present, we just went ahead with a freehand buildup, and later we can remove all the overhangs with the backbone. So there we would end up the first visit, the root canal treatment. A single visit root canal treatment was completed. A gingivectomy was done to protect the gingivectomy site and to hasten the healing. A COE pack is given over here. Now that is the visit 2. All the dentin has been replaced, and you would see that there is no post and core, nothing is involved over here. And then we would scan this, and a lab fabricated Emax onlay would be bonded onto this tooth. So the onlay is back from the lab. We have to go through all the protocols of porcelain bonding, like hydrofluoric acid etch, silination, bonding agent application, all those things, the routine protocol. And the final overlay is being bonded onto the tooth. Now, the most frequently asked question when we talk about such management would be, will this last? Won't this break? So something which we have to understand is, gone are the days wherein dentistry was just based on drilling and then filling the drilled spaces with a filling material or restorative material. See, when we make the tooth overtly strong, what would happen is the bond as well as the TMJ goes for a toss. So what we are supposed to do is we have to make the tooth withstand the forces, or rather we would enable some sort of flexion inside. That is, in the natural tooth, the enamel takes up the load, and the load via the dentino-enamel junction is transferred onto the dentin. So what does the enamel do? It actually absorbs the forces and sends it into the dentin through the dentino-enamel junction, which would function like a cushion, and it would help to lessen the impact of these forces. So that is what happens on a natural tooth. And when we restore a tooth, the same thing we have to recreate. Let's see how these things are done. That is what we are going to deal with in today's session. So you can see the preoperative as well as the postoperative pictures here. Now, we have to understand that the forces accumulate on the pericervical area. So this is the Moyer fringe study. What you see on the screen is the Moyer fringe study, which is showing us that the most crucial zone where the stresses are going to concentrate would be the pericervical zone. So now let's see what is the pericervical zone, or what is the significance of this pericervical area. One of the main concerns in restoring a badly mutilated tooth would be preserving the pericervical area. And that never happened in conventional dentistry. And hence, we landed in catastrophic failures. So let me explain more about this. And in this picture, so this was first reported by Clark and Khadami. So you can see the pericervical area would be those regions which is 4 mm supracrestal to the alveolar bone and subcrestal to the alveolar bone. Fine, this is a very crucial zone. We have to understand that this area is crucial in transferring the occlusal load from the occlusal table to the root. Also, we have to understand pericervical dentin is irreplaceable. That is, no man-made material or technique can replace the pericervical dentin. So let's see what happens when we treat a tooth. So the biggest problem we face in dentistry would be we over-engineer the tooth. That is what is always happening in conventional dentistry. To do a small thing, we would think too much and we would land up in over-engineering the tooth and getting results which is not worth the efforts that we have taken. That is, in spite of taking all this struggle, the tooth would land up in a premature failure. So let's see this case, a beautifully root canal treated case. Fine. So the beauty of our good work goes waste because of our unplanned, poorly engineered coronal restorations. So you can see the root canal treatment we did justice. You can see all the isthmus between the mesiobuccal and mesiolingual is being filled. And you can see the distobuccal, distolingual, the lateral exits, isthmus fills, anastomosis, everything. So when we do a root canal treatment, we actually have removed some amount of pericervical. Fine. But again, as always it is said, every restoration is a bag of compromises. So to save the tooth, there is no other option but to do a root canal treatment, and that has landed up in significant loss of the pericervical dentin. Now, we would say that to rehabilitate this tooth, we have to go for a crown. And see what we do when doing a conventional crown preparation. Again, we remove the pericervical dentin. Fine. Now, sometimes by thinking that we are going to strengthen the tooth more, we put a post also. So everything is a total mess. We have a proper recipe for a failure. Fine. So a crown after a root canal treatment can be poor engineered. Some technical issue. You all are hearing me?
Yes, sir.
One second. Yeah. Maybe some network issue, I think. Yeah. Now, we have to understand that, see, the tooth in 1996, Dr. Rainey, he discovered the Rainey's ridges or the subocclusal oblique transverse ridges. As you see in the picture, you have ridges which is running through the dentin, that is subocclusally, which is cross bracing the buccal as well as lingual vespal elements. So when we do a tooth preparation, what would happen is we sever through these ridges and the tooth becomes too weak. And that has been pointed out by many eminent researchers like Larson, who has proved that a cavity prepared tooth is always more weaker than a decayed tooth. Fine. So cavity preparation, conventional tooth preparation is actually weakening the tooth. Fine. So these things were unknown to us. Fine. And the same happens with the maxillary teeth. The mesial fossa has the suspensory web of enamel, which is also severed when we do a conventional tooth preparation. So now we have to understand how to avoid all these things and restore a tooth. When we restore a decayed tooth, we have to rebuild it just like an intact. So that is what happens in biomimetics. So let me start with the concepts of biomimetics. So in biomimetics, the first thing which we give prime importance to is that is for preserving the vitality of the tooth. Then we have to preserve as much as possible as that of the tooth structure. Then we have to improve the biomechanics. That is normally when we do a restoration, due to the tooth preparation protocols, what is happening is, or rather when we chase down the caries, what happens is the tooth becomes irreversibly damaged and weak. So we may have removed all the decay, and while doing so, we have rendered the tooth irreversibly weak, or we never focus on the biomechanics. So now we have to give maximum importance to the biomechanics, because this is the thing which is going to enable the tooth to be in function for a long time. So we always strive to improve the biomechanics. Then, when dealing with adhesive restorative material, something which we can never avoid is the polymerization shrinkage stresses. We know that is a drawback of the material. So we may have to do some modifications wherein we can mitigate the effects of polymerization shrinkage stresses. That is, we can reduce the problems caused by the polymerization shrinkage stresses. Let's see all these things. So now at this juncture, let me remind you all, there are certain things which are mandatory in following the biomimetic protocols. The first thing being magnification, not only in biomimetics, but also in any form of modern dentistry. Magnification is very important. So that is my operatory. What you see over there. So if not, it's a microscope. We have to go towards loops. So some form of magnification is very important. As in the previous case, which we discussed, we were talking about identifying and rectifying the cracks. For you to see the cracks, we need magnification. So magnification is very important. Another thing which is equally important is introduction of an air abrasion unit in your operating. It can be anything from the crystal marks unit to aquacare, or even the most economical intraoral sandblasters. So some form of air abrasion is mandatory. Then we need caries detector dyes. We are never going to focus on the texture of caries. We are never going to excavate the caries, nothing. We would be removing the caries based on what the color indicates to us by the caries detector. So let me explain my journey from silver amalgam restorations to biomimetic dentist. So right from my post-graduation days, my focus was always on restoration of badly nucleated. So I started with silver amalgam restoration. So you can see the pin retained silver amalgam restorations and all over there. This is something which at one point of time I used to do. Then, after many years, we started seeing the problems associated with silver amalgam. So in silver amalgam, though the restoration stays for long, what happens is the tooth gets more damaged. And you would have seen such type of fractures very often with long-standing silver amalgam restoration. That is either the buccal or the lingual wall breaks off. And when that is a decay tooth, what would happen is there would be many micro cracks. And then what would happen? The patient comes to you complaining of pain when biting down. So this was something which we could never correct. We always used to do a root canal treatment and then restore the tooth. That is, whenever we had the problems associated with cracks, whenever there was a pain when the patient bites down because of these cracks, we were never able to fix them by avoiding a root canal treatment. Very often we did root canal treatments. So that is something which is wrong. The tooth was still whitened and there is no point to sacrifice the vitality of the tooth to restore it. But again, it was not possible. So that is one big problem with silver amalgam restorations. So you can see a similar situation, but another case. So you can see small two class 1s, 2 pits are filled with silver amalgam, and you can see the cracks running along the distal margin. So you can see the cracks. Fine. Again, the problem, the clinical manifestation is going to be the same. Pain when they bite. So let's see how we go ahead with the restoration. So this is the first phase, wherein we call this as creating the biobase. So I have dissected all the cracks. We have went deep, acquired the deep margin, removed all the cracks, and elevated the deep margin. And you can see that in the picture. But the problem is, these things were never taught in dental schools. So when we came out from the dental schools, when we start practicing, these things become a big issue. That is, neither we are taught about these things, nor do we have the skill set which is required for doing all these procedures. These are very simple things, but the thing is, we are not exposed to such type of dentistry when we do our graduation or post-graduation. Again, another problem. That is, I have explained the problems that was happening with silver amalgam restorations. Still, there was problems with composites also. Fine. So we always find ditching of the margins. In our composite restorations, maybe after 1 year or 2 years, when the patient turns up for a follow-up or for any other restoration, we would see our restorations are ditched along the margins. But again, that is not a big issue because we can finish the margins and make them as something which is just like a new filling. But the problem is the non-vitality these deep restorations bring forth. So in this case, you can see there is a periapical lesion. We had, this is my case only. I had done a composite restoration some years back. And after a few years, the patient came with pain on the felt tooth. And IUPA was exposed, and this is what we have seen. No other option but to go for a root canal treatment. So we have seen the problems caused by silver amalgam restorations as well as composite restorations. There is no other go but to go for a root canal treatment. The root canal treatment was completed, but we never give a crown. So you can see in this picture, we have gone ahead with a bonded porcelain overlay here. Now, I'll show you 2 real game changer cases. So something or these 2 cases changed my perspective about adhesive dentistry or my perspective about adhesion-oriented restorations. So you can see here The tooth was root canal treated, the first picture. Fine. On the top right. So pain vanished after the root canal treatment. The patient too. And after a few months, he came with pain. An IUPA was exposed. It was a suspected root fracture. And the second picture, you can see the fractured tooth was extracted. You can see that. The segments were stuck back. This picture. And this tooth, which was stuck, was reimplanted in the socket. I followed up this case for 2 years. Later, this was taken as an abutment and a bridge was. The bridge is there in service for the last 12 years. Fine. So I'm convinced adhesive dentistry works. The next issue was deep composite restorations. Fine. See, we have to understand something, that is composite restorations, when we have the right choice of materials, they actually protect the pulp. That is, the base of our hybrid zone is converted into an acid-base resistant layer by the gold standard bonding agents. And this is the pulp protection. We have to understand that no calcium has ever protected any pulp. Fine. So gone are those days. Pulp protection is by immediate tendency. So the tooth was rubber dam isolated, and you can see there's a class 5 which is extending as a proximal lesion onto the mesial side as well as distal side. And while excavating, I have exposed from the mesial side as well as distal side. So this is a case wherein the tooth was selected for a root canal treatment. Fine, we had planned on a root canal treatment. And the patient was was very known to me. We were treating her from the almost the first few months of starting my practice. So I thought, anyway, I have to do a pre-endodontic buildup. So I'll just go ahead with excavation, landed in exposure. Then there was the 6th generation bonding agent, the Careful SE bond, which I had bought just to try out, because it's like I have read in the literatures that these things are going to protect the pulp. So I went ahead with all the protocols of immediate dentin sealing. I guess there is some network issue. Am I audible?
Yes, sir.
Sorry, just give me a second. There's some lag in the network. Yeah. So went ahead with matrix placement, and the restoration was complete. So you can see we did this case in 2018 and you can see the follow-up in 2024. Still, the tooth is vital. So all our thoughts regarding pulp protection is now going to be different. We have understood that we don't require calcium hydroxide or something like that. It is actually our composites going to protect the pulp. Now you can see another case wherein it's a class 5 along the buccal side as well as the palatal side, along with the distoproximal side. And still, we can avoid a root canal treatment and make the restoration stay for long if we abide by the protocols of biomimetic dentistry. So let's now see how to manage a case biomimetically. The most sought out technique would be the 6 lessons approach, which has been proposed by Dr. David Lehman. So now coming on to lesson 1. In the lesson 1, we focus on giving a firm foundation for the restoration. And here we are not doing a total caries removal. This is a technique which is completely based on partial caries removal. So the caries removal endpoints are established. And when we establish the caries removal endpoints, we would be able to assess the hierarchy of bondability in that case. I really know that very few might have understood about the hierarchy of bondability. I'll explain. Now let's see how we would establish the caries removal endpoints. So we are staining the decay with the caries detector dye, and you are supposed to remove everything that is staining red. That is the outer caries dentin. The inner caries dentin, which stains pink, can be left. And at the same time, circumferentially, 2 mm into the dentin from the dentino-enamel junction has to be devoid of all sorts of outer caries dentin as well as inner caries dentin. It should be sound dentin. Fine, that is very important. And sometimes we would be forced to leave a bit of caries if the tooth is vital. That is to prevent exposures, prevent pulp exposures. So here something which is going to guide us would be just a simple instrument, the periodontal probe. So occlusally, we never go more than 5 mm, and proximally, we never go more than 3 mm. If you can stick to this rule, you would never expose the pulp. Fine, it's very simple. So let's see the video of how these things are managed. So I have a caries premolar. So first thing that we have to do is we have to go ahead, expose an IUPA, see how the IUPA looks. We have to look for any periapical changes. And then we have to, if at all the tooth is asymptomatic, we have to go ahead and see for the vitality of the tooth. And if at all, by the cold test, the tooth, if at all we find it vital, then we would be avoiding a root canal treatment. Let's see the protocol. The first thing should be we have to go ahead with rubber dam isolation. And here you can see that after the rubber dam isolation, a bit of Teflon was used to acquire the deep margin. So there are n number of techniques which would help us to acquire the deep margin, this being one among that. So a very, very tricky thing. I mean, it's like very handy thing. We don't have to think about too much of things like a retraction cord or something like that. Just a Teflon, a small bit of Teflon is going to save life. We would apply the caries detector, and you can see the video. I guess the video is playing, right?
Yes, sir.
So here I'm using a round bar. And establishing the peripheral seal zone. We would apply the dye again. Wash off. Still there is demineralized areas across the peripheral seal zone. Have to remove that. And you can see the thin enamel flaking off. You're not supposed to have unsupported enamel at all. Still, there is demineralization across the DEJ. We have to apply the caries dye once again. Likewise, we would apply the dye, check for demineralized areas. If there is some demineralization, we would remove that. And similarly, the peripheral seal zone is established. And thus, peripheral seal zone is very important. That is what is going to prevent the leakage, which is going to protect the caries from the oral environment. And you can see that is what the tooth looks like after the selective caries removal, and no more box type preparation. So here in this preparation, if you see the C factor, it would be like one bonded surface and one unbonded surface. So never prepare the box type preparations. That is never going to work in adhesive dentistry. So let's have a look into this picture. So after establishing establishing the caries removal endpoints, we can see certain structures inside. That is, we can see the beveled enamel superficially, which would give a bond strength of about 30 to 50 megapascals. And then we have the outer caries dentin, wherein we would lose the bond strength by 70%. And then we have the inner caries dentin, which we are going to leave. And we have to expect a 30 to 50% reduction in the bond strength here also. So these substrates are going to work differently to the bonding agent or differently to bonding of your composites. So we may have to think about different bonding strategies in these different areas so as to get a very successful restoration. Then coming on to lesson 2. Lesson 2 is about evaluating and treating the horizontal as well as vertical structural compromises. So this is very important. See, actually the lesson 2 comes before the lesson 1. Whenever we are going to start with the restoration, we have to assess whether the tooth is strong, whether the skin stay for years together. So how do we assess the horizontal as well as vertical structural integrity of a tooth? Let's see. So we have certain criteria here. Isthmus wider than 2 mm. That's a compromise. Cusp, which is thinner than 3 mm. again, the tooth would be compromised. So you can see here, when the cusps were thinner than 3 mm, what happened? You can see the thin cusp would fracture up. And you can see what happened when the isthmus was wider than 2 mm. The restoration or the tooth or both are going to fracture off. Fine. Then the third factor, peripheral rim fractures. Again, you can see the peripheral rim fractures. Why? Because the tooth flexes when there is nothing in between due to the forces from the opposing tooth. The buccal and lingual cuspal elements, they flex outwards and all these catastrophic failures happen. And then all boxes deeper than 4 mm is a big issue. So first, when you see a case, you have to look out for these factors. And if you find these things, you have to be literally careful. So let's see how to manage. So you can see a similar case over here. You can see peripheral rim cracks. You can see fractures. You can see wider isthmus. You can see thin down cusp, everything. So as I told you, we don't have box type preparations. So this would be the modern preparation, wherein there is all unsupported enamel we have trimmed off. There is nothing over here in this tooth to flex and fracture. That is, the tooth is converted to an anti-fragile design. On top of this tooth, which is resisting all types of fracture, which is strong on itself, we would be building up the lost enamel. That's what we do in biomimetics. Now, after establishing the caries removal endpoints, the exposed dentin should be sealed. Immediate dentin sealing drastically improves the bond strength to the dentin. After immediate dentin sealing, we'll go to lesson 4, wherein we have to control the C factor by decoupling. That is, we have to allow time for the immediate dentin sealing to mature, the hybrid zone to mature, the bond strength to become maximum. And then we go ahead placing the rebond fibers. Rebond fibers, it's like they do a lot of advantages. That is, one is it functions like a flexion mechanism inside. It absorbs the stresses. Another thing is it would distort on its own due to the polymerization shrinkage stresses, thereby preventing the delamination of the composites, which is adhering to your inner carious dentin or outer carious dentin. It reduces the C factor drastically. All these are the advantages which the fiber placement gives. So you can see the protocol. I have a deep proximal lesion here, and the deep margin acquisition has been done with a copper foil here. I've left some caries over there, so I'll be doing the immediate dentin sealing. Then you can see in the picture, I've placed the rebond fibers. Then I would be covering them with a small layer of composite again. So now the entire dentin is replaced. We call this the bio base, and it's time for enamel replacement. And let's see how we do all these immediate dentin sealing, etc. Let's see a video. So we apply the primer, air thin the primer, then apply the adhesive. We have to blot away the excess adhesive with dry applicator tips, cure it. Then we would apply a small layer of flowable composite over that, which is called the resin coating. Once this is done, we would leave it for 5 minutes for the bond to mature, and then this composite would be connected to the enamel outside. That's called decoupling with time. Fine, and you can see me placing the rebond fibers. Let's see one more case, a video. Here the deep margin is acquired with a wedge. And then after the caries detected I would be starting with the selective caries removal. And just see what the wedge is doing. It is acquiring the deep margin. At the same time, it is protecting the burr from skidding and nicking the adjacent tooth. something which you all can try. A simple wedge can always prevent skidding of the bird and nicking the adjacent tooth. So you can see the selective caries removal here also. And now we'll see how we replace the enamel. Again, before going ahead with the enamel replacement, we have to make sure that our preps are relatively flat and divergent. We have to preserve the thick functional cusp, if possible. Then we have to go ahead with air abrasion, and enamel replacement would be done either with stress-reduced direct composite restoration. Sometimes we may have to do semi-direct restoration or semi-indirect restorations, or we would bond indirect restorations with heated composite. So let me come again once again. Enamel replacement is done either with stress-reduced direct composite restoration, with semi-directs or semi-indirects, or indirects with heated composites. So these are the different techniques of enamel replacement. So let's see a case. So all the dentin is being replaced. Let's go. This is the preoperative picture of that case. Very deep caries. Selective caries removal. And there was an accidental pulp exposure also. We went ahead with a bit of light cured calcium hydroxide just as to act as a mechanical barrier. Something, let me remind you, this is not a pulp protection. It is just to act as a mechanical barrier. But again, I didn't get the advantage of that when I was scrubbing my bonding agent. You can see the calcium got dislodged. So immediate dentin sealing was done. Fibers were placed. You can see the onlay from the lab. The onlay was bonded. Fine. And you can see the follow-up of this case. The Java has adapted nicely. Root canal treatment was not done. Fine. So we need follow-ups, further follow-ups to make sure that the tooth stays without the root canal treatment. Still, we can say that the case is 100% successful. So far, it's going on fine. Let's see another case. Again, deep caries lesion. Caries removal endpoints are established. Immediate dentin sealing is done. And we would replace the enamel with an indirect bonded porcelain overlay. So again, we can avoid a root canal treatment in such cases. You can see the rubber dam isolation. The overlay being bonded. So this case we had discussed in the beginning, a fractured lingual cusp, an old silver amalgam restoration, and the patient complains of pain on bite. So the mesial side, we plan to do a direct composite buildup, which was done. And after air abrasion, so when we air abrade, we protect the adjacent teeth with a bit of matrix band. And you can see the crack being dissected. So once the cracks are removed, we have to go for acquiring and elevating the deep margin. Again, it's been done with a copper foil here. So copper foil is something which is really good in acquiring the deep margin, and it is inexpensive also. It's really economic. Again, you can see immediate dentin sealing followed by fiber placement, and the tooth was restored with an Emax only. So lesson 6 is about occlusal adjustments. So in doing the occlusal adjustments, we make sure that there is no lateral stresses acting on the tooth. And for that, we have to check on the maximum intercuspation positions as well as the excursions, and thereby we make sure that there is no lateral stresses which is going to come on the restorations. So this is the 6 lessons approach. So I had shown the video of this case. And now, once after the caries removal endpoints are established, you can see it's a compromised structure. We'll go ahead, acquire the deep margin. We have to do immediate dentin sealing, fiber placement. The adjacent tooth was restored since there was a class 2. So here I am doing a different technique called delayed direct for enamel replacement. The heated composite was injection molded here, and that's after finishing and polishing. Again, we could avoid a root canal treatment. So these techniques work well with anteriors also. A case with a huge lesion. This was apexification was done long back with MTA, again restored with a metal post and core. The post was retrieved, MTA was removed, etc. And you can see the tooth was totally badly mutilated. We didn't go for a crown. After the root canal treatment was completed, after the retreatment was completed, the roots were reinforced with ribbon fibers. You can see we have placed a high molecular weight polyethylene post also here. Wait, the picture is changing. It's taking a bit of time. Yep. That's the ribbon post. Then we would replace the enamel with injection molding and finishing and polishing. That's the follow-up of this case. And you can see the lesion is also healing. So no more post and crowns. So with this, it's time for us to wind up. I'll show one more case. You can see this case. It's a lateral incisor which is badly caries. After the caries removal, selective caries removal, in fact, it is only a thin structure. Again, pulp is not exposed. And let me tell you, magnification is something which is very important in such type of procedures. And you can see the remaining two structure. Immediate tendon sealing, matrix placement, the final restoration. Still, we would always struggle to avoid a root canal treatment and maintain the vitality. So with this, let me finish. And all these things are possible by these two great men, Dr. David Aleman and his son, Dr. Devi. They are my mentors, and they are the people who opened up the world of biomimetics, or the ultimate art and science of restoring the tooth. So with this, let me wind up, and quickly we'll have a quick session on clearing your doubts. If at all you have some doubts, you can unmute and ask yourself. Very quick session. It's already 9:30. Hmm. 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 Invited. Huh. Okay.
So thank you so much, sir. So we will have a
Yes,
quick,
Anup.
yes, sir. Quick question answer session. So let's see if we have any questions regarding. So I would request the audience to please post questions which is relevant to the topic only. So let's see any yes. Okay, so there's one question regarding about the bonding agents. So do we need to use both the Clearfill AC as well as universal bonding agents for such to manage such cases? Is it so?
We use only careful SC in such cases. We don't use universal bonding agents.
So I think most of the doctors are asking questions regarding about the technique and the finishing and
Yeah,
polishing
I
protocols.
was just going through. I was, and even people are asking for the charges also. It's like, see, nothing comes cheap, huh? It's like we may say that we may charge more than a root canal treatment to avoid a root canal treatment. That's the best way I would find to put it across. And let me tell you one thing. This is an intense topic. A lot of things, and it is something which we may need to discuss for a longer time to make you all understand and convey the concepts. So, if at all you guys are interested more in biomimetics, you can always join our workshops. You can follow me on Instagram, wherein we would be updating regarding the courses, or you can also contact IADP for the information regarding our clinical workshops. Fine.
Yes, sir. So as sir has mentioned, we do have a workshop regarding about biomimetic dentistry, which is conducted on 4th, 5th, and 6th of this month in Ernakulam. So if anybody is interested to register, you can contact the mentioned number. Just let me put it on the screen. Just hold on. So as you can see, it's regarding about biomimetic dentistry. It is a 6 lessons approach. And it's going to be on this month, 4th, 5th, and 6th of October in Ernakulam. So if anybody is interested, you can contact me this mentioned number. So
Or you guys can do one thing. It is like you can follow me on Instagram. I would just do my screen share. Okay, give me the details.
Sure, sir.
regarding. So that is where you would find me on Instagram. You can always log into Outlook Center for Advanced Dentistry, and you will find all these tricky cases, challenging cases, as well as you will get the details regarding our workshops. Also, you can contact IADP for the information regarding our workshops. So with this, shall we wind up, Dr. Shanu?
Sure, sir. Definitely, sir.
So thank you all. Thank you for the patient hearing.
Thank
Good
you
night.
so much, sir, for sharing your knowledge and expertise when it comes towards the biomimetic dentistry. So surely many of us would leave this discussion with amazing takeaway points and implement techniques as per discussed. So thanks to all the doctors for patient listening and your participation for this webinar. And I hope all of you will depart this session with positive, confident manner. So once
And
again, thank you so
also,
much, sir.
something. I mean, let me say a few points. If at all you want me to explain on some topics like deep margin acquisition, elevation, which bonding agent to use, etc., some short topics like that, please do let us know. We can do another online session regarding all those things. Okay. So
Definitely, sir.
yeah. So good night, guys.
Thank you so much, sir.
Thank you, Shanu.